Anesthesia management of bronchial lavage for the patient with alveolar proteinosis. This presentation assumes familiarity with the placement of double lumen endotracheal tubes and significant experience of both lung isolation and one lung ventilation. This is a prerequisite for performing this anesthesia technique. Only one lung is treated at a time, never both. The intent of this procedure is to be able to run copious volumes of warm normal saline at low pressure into the lung being treated without causing alveolar damage. When the lung is full of saline, the surgeon performs 5 minutes or so of brisk percussive chest physical therapy to loosen the sticky surfactant secretions, and then the warm saline is allowed to drain out of the lung without exposing the delicate alveoli to strong negative pressures. And of course, we must be cognizant of avoiding the potential for fluid overload at all times. This procedure is essentially drowning a lung, and there will be some degree of post-operative respiratory dysfunction in this lung. So again, only one lung can be treated at a particular session, never both, and an interval of at least a week or two before the other lung is treated allows time for return of normal respiratory function in the treated lung. Normal lungs secrete surfactant into the alveoli to maintain alveolar stability and to prevent alveolar collapse. Those poor patients born with an abnormal gene produce abnormal surfactant, which cannot be adequately cleared by alveolar macrophages. And so, this abnormal protein gradually accumulates in the lung and may lead to respiratory failure. This condition is called alveolar proteinosis. It may be effectively treated by intermittent lung lavage to remove the lung's burden of abnormal protein. As an overview, this presentation will focus on the treatment of just one lung, the more severe lung. So, the patient will be intubated with a double lumen tube. The patient is placed in the lateral position with the operative lung uppermost, and the ability to isolate the operative lung from the dependent lung is confirmed. One litre of warm crystalloid fluid, preferably normal saline, is run into the upper lung. Chest percussion is performed to loosen the sticky secretions. This is done by the surgeon. Then a very cloudy milky white fluid is drained out of the lung, and lung lavage is repeated in this way until the milky colour of the drained fluid has dramatically cleared. And this may take between 12 and 15 litres of irrigant fluid. So let's look at this in detail. The anaesthesia management of bronchial lavage for these patients includes all the requirements for high quality thoracic anaesthesia. A familiarity with these requirements is assumed. The management of bronchial lavage will be unfamiliar to many anaesthesia providers, and so I describe it here in detail. An arterial line should be placed for arterial blood gas monitoring in all patients undergoing one lung ventilation, and this is usually placed in the upper limb opposite the treated lung. General anesthesia is induced and a non-depolarizing muscle or laxant is administered. A well-placed double lumen tube is essential, and optimal positioning of this tube should be confirmed using a fiber optic bronchoscope, both before the move into the lateral position and after the patient is in the lateral position. With both the tracheal and the bronchial cuffs carefully inflated, excellent lung isolation is confirmed by the ability to ventilate the dependent lung without a gas leak to the non-dependent lung. Similarly, it is important that irrigant fluid should not be able to leak from the non-dependent or upper lung to the dependent or lower lung. This is confirmed with a leak test, which is designed to detect the leakage of gas from the operative lung to the dependent lung. The end of the double lumen tube, the appropriate lumen of the double lumen tube, is placed below the level of water in a small bowl, and a Valsalva maneuver is performed, and you observe to see if bubbles escape from the lumen of the double lumen tube serving the operative lung. Then, gradually increasing pressures from 20, then 25, 30 to 35 millimeters of mercury are applied, looking for evidence of these bubbles from the lumen of the DLT. They should be absent. Now, construction of the bronchial lavage circuit is described in the next section, and monitoring and access ports in the tubing will allow monitoring of the pressure during both the inflow and the outflow phases. As will be mentioned later, the yellow cap is removed from the sterile end of the middle section of the lavage system, and the connector is pushed firmly into the connector on the appropriate lumen serving the operative lung, and this will be covered in detail later. Do not push this in so firmly that removal is impossible, because the lavage system must be disconnected from the double lumen tube to re-inflate the lung when the procedure is completed. Now, all this will make perfect sense when you look at the sister presentation, the accompanying presentation to this, on the construction of the lavage circuit. Management of bronchial lavage. Up to 15 litres of normal saline should be placed in a warming cabinet 24 hours before the start of the procedure, and should be at 37 degrees Celsius on the morning of the procedure. This can be confirmed by simply placing an adhesive liquid crystal skin temperature monitor on the bags to ensure that it remains warm, has remained warm. 1 litre of warm normal saline is attached to each of the 2 inflow ports on the distal part of the lavage system, as shown in the accompanying pictures, and they're hung from a drip stand. The starting height for the top of the bags of warm saline should be no greater than 30 centimeters above the midpoint of the lung. Similarly, the starting height for the midpoint of the lung should be no greater than 30 centimeters above the base of the drainage canister. This can be achieved by raising the metal surgical bucket containing the drainage canister on a few little surgical steps or supports to raise its height off the floor. All of this is illustrated, again in detail, in the video on construction of the circuit. Let's consider the inflow phase of the first lavage. When it is appropriate to commence the first lavage, we must close the outflow or drainage limb and then open the inflow or irrigation limb on the circuit. A metal clamp, shown, is used to close the outflow limb of the system. Another clamp, which is including the inflow limb of the transurethral resection irrigation system or TUR irrigation system, is opened to allow a litre of warm saline to run into the patient's upper lung. It is essential to carefully monitor the inflow pressure throughout the entire inflow phase. In the first lavage, keep the inflow pressure to less than 25 millimeters of mercury, as high inflow pressures can of course rupture alveoli. If the pressure is rising rapidly, it is about to exceed 25 millimeters of mercury, use the clamp to slow down the infusion rate on the inflow limb. Alternatively, the vertical height of the fluid above the lung could be reduced by decreasing the height of the drip pole, but the clamp is more convenient and more rapid to effect. When 1 litre has entered the lung, the inflow clamp is closed again. While the lung is full of irrigant fluid, the surgical team will perform vigorous percussive physical therapy on the lung to gradually release the sticky protein. And the anesthesia team will alternately rotate the patient position between slightly head up on the table and slightly head down on the table, left lateral tilt and right lateral tilt, to make sure that the normal saline gets to all portions of the lung. When this percussive session is done, the surgeon requests that the metal clamp is released to open the outflow or drainage limb, and fluid is allowed to drain into a suction canister placed below the height of the table under the negative pressure of gravity. But be careful here. Start with the suction canister perhaps 25 centimeters below the height of the table. Excessive negative pressures can also damage the alveoli, as they do in negative pressure pulmonary edema. So look carefully to exclude a pink tinge to the drainage fluid, which should be a clear, well, a milky white, but there should be no pink tinge to this milky white cloudy fluid. It starts very milky and it should become increasingly clear with each irrigation. Each full drainage canister is kept and inspected for gradual clearing of the drained irrigation fluid for evidence of complete removal of the lung's burden of abnormal protein. And you can see in the picture, the accompanying picture, the clearing of the cloudy colour. For the first few cycles, the outflow volumes may be less than the inflow volumes, as fluid finds places within the lung to be sequestered. However, as these spaces are filled, the inflow and the outflow volumes will gradually equalize. Any continuing disparity of inflow and outflow volumes should prompt a search for leakage. Look for pools of fluid on the floor, or look for damp linen at the head of the patient's bed. At the end of the lavage, which may be as much as 12 to 15 litres, the net inflow and net outflow volume should be no more than about 100 to 300 mLs positive or negative. But if you have a discrepancy and you cannot account for it, you must assume that there is excessive absorption of fluid and you may be heading towards fluid overload. So you may have to decrease your infusion pressures or your inflow pressures. During subsequent inflow phases, the height of the fluid above the lung may be gradually increased so that inflow pressures increase towards a maximum of 30 millimeters of mercury if you're happy that there's not excessive absorption of fluid. In the outflow phases, the drainage canister may be lowered towards the floor until the height of the lung above the canister generates a maximum negative pressure of approximately minus 30 millimeters of mercury. Providing there is no evidence of pink blood staining the drained lavage fluid. Then, cautiously increase inflow and outflow pressures, allowing for faster irrigation and drainage of the lung, as long as, once again, you don't have a horribly positive fluid balance. At the end of these inflow-outflow cycles for each litre of fluid, you have to be very, very careful about letting the pressures increase very gradually. Caution is essential. So, if we do 12 to 15 irrigations, the first 4 or 5 must be at low pressure, low positive pressures filling the operative lung, low negative pressures draining the operative lung. But as we proceed, we can cautiously increase both the positive pressures of the inflow of irrigant and the negative pressures of the outflow of drainage fluid. So towards the end of the procedure, we should be getting fairly brisk and excellent quality irrigation of the lung at slightly higher pressures for the inflow and for the outflow of fluids. This may help really clear the lung of the heavy burden of this abnormal protein. And you can see from the accompanying photographs that the milky colour in the drainage fluid should gradually decrease and decrease until there is very little protein left in the drainage fluid in the last few cycles. Thank you for listening to this presentation on a very challenging subject.